Hello and welcome to our first session. Today's presenter is Dr. Howie Tran of the University of California, San Diego. Dr. Tran is a board-certified transplant cardiologist specializing in treating advanced heart failure patients at the University of California, San Diego. Dr. Tran is the medical director of cardiogenic shock, mechanical circulatory support, and left ventricular assist device. In addition, he's the medical director of the heart failure program at UCSD. He specializes in treating complex cases of heart disease leading to heart transplantation or mechanical circulatory support devices. His full bio is available in the lobby. The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association, and the materials are for educational purposes only. They do not constitute an endorsement or instruction by AHA-ASA. The AHA-ASA does not endorse any product or device. As I mentioned, Dr. Tran's full bio is available in the lobby if you'd like to read more, but we are excited to welcome him. And Dr. Tran, I will turn it over to you.
Great. Thank you so much. Let me start to share.
All right, there we go.
Okay. Kelsey, thank you so much for the very, very nice introduction. And I apologize about not being there live with you. I am in the cath lab and I also have my MBA classes to attend to. But today, let's talk about the optimal timing of referral for heart failure specialists. We deal with this all the time. And I know that in the audience, we have a fair amount of cardiologists who see patients with heart disease, heart failure. And the question is, well, when is the right time? We have a fair amount of APPs as well too, some PAs and NPs that are in the audience. So I'd like to address what mechanisms are important. What do you look for a patient that has end-stage heart disease that like to send to an advanced center? So we have a lot to talk about today. I won't be talking about devices so much. I am a speaker for both Abiomed and Abbott, and that's not so important for this talk. What's really important, though, for me is as I hire folks for our program, I think it's very important to know that this statement and this quote from Steve Jobs is so important to us. It doesn't make sense to hire smart people and tell them what to do. We hire smart people so they can tell us what to do. And what you're going to see is an amalgam of very smart folks that we've hired that really built up this program, and we're very proud of this program. Our discussion summary today, we'll spend some time talking about the challenges of advanced heart failure. We'll take a look at the San Diego landscape and how we've built in our landscape about 10, 15 years ago. We'll take a look at our UC San Diego referral process. We'll take a look at patient identification for advanced heart failure therapies as well. What does the team look like? And then finally, if time allows, we'll take a look at employing remote monitoring. And I won't be the only one talking about this. So if we don't have time, we can talk about it another time when we have more venues. So the challenges of advanced heart failure, and this is straight out of the AHA. And I'm going to take some time to thank the AHA for having these initiatives for cardiologists and practitioners across the country. We know that a huge amount of our patients have heart failure. About 6.2 million folks living in America with heart failure. Close to 600,000 of those are in the advanced stages. Half those patients will die annually, right? So 300,000 patients die annually of heart failure. 50% mortality within 5 years, and it is a huge burden on our economy. 31 billion folks, $31 billion in the US for the care of patients with heart failure. The leading cause of hospitalization in US and Europe, you've got it, heart failure. It's the highest readmission rate of any diagnosis related group, 20% at 1 month and 50% at 6 months. We know from our last AHA analysis, this is roughly about 10 years ago, a little more than 10 years ago. But when you take a look and extrapolate from 2020 and then moving forward to 2030, we're anticipating about 8.5 million individuals with heart failure in 2030. That is a prevalence that's increasing to about 46% by 2030. And patients with heart failure will rise up to about 8 million, as you can see in 2030. What is the economic burden of this, though? We estimate that it'll rise up to about $70 billion by 2030, a twofold increase from 2013. These are direct and indirect costs that are being analyzed. So 80% costs are related to hospitalization. So we have to do a better job at figuring out what we can do for some of these patients. And the San Diego landscape is very interesting. And when I joined here back in 2014, 15, we had, let's see, about 30 some odd LVADs, about 18 transplants during the time. And we made a decision to get out there and really build this program, a true hub and spoke model. I want to share with you a little bit about the landscape that we have here in San Diego. Now, we're down here, San Diego proper. We're right next to the US-Mexico border. A lot of these places and blue dots that you see are areas that we have outreaches to. We have an academic mission to get out there to the community, particularly in the areas that are underserved, and get patients in. I have a satellite clinic up here in Temecula, Murrieta, and a lot of our faculty members will have satellite clinics as well too. But the idea is to bring the resources that we have at UC San Diego out. Your institution is probably the same. It's figuring out, well, how do I get our satellite clinics out there? And for those of you who are referral centers, this message is very important for you, is at what point, what is your threshold in sending these patients into these spokes to make their way to the hub? So I'll speak a little bit about that. About 10, 15 years ago, we ended up developing relationships across the board in Southern California. We have a relationship with UC Irvine. UC Irvine sends us a fair amount of patients that are geared up for heart transplantation. I'd like to congratulate UC Irvine as they are now a heart transplant capable center as of 2025. Roughly about 2-3 weeks ago, we got that news. So we get a fair amount of patients from UC Irvine. Riverside Community Hospital, you can see Scripps Memorial down here. Sharp Memorial as well too. Mission Hospital in Orange County, St. Joe's and Medical Center. It's a lot of hard work trying to create these relationships and bringing these cardiologists into our mission as well too, and indoctrinating a lot of our cardiology friends with the idea of heart failure care and how we do heart failure care took a lot of hard work. And I'm here today to really share a lot of that. So let's talk about the UCSD referral process. In order to do that, let's talk about a story. Those who tell stories rule society. So here's our first clinical case. We have a 64-year-old gentleman who has ischemic cardiomyopathy and LVF of about 25%. He's had CRTD, hypertensive disease, chronic kidney disease, and diabetes, not on insulin, hyperlipidemia, who was evaluated after his third admission for acutely to congenital heart failure in the past 4 months. And he's sick of it. He's sick of coming back in the hospital. His quality of life isn't that great. You know patients like this because you have these patients on Entresto. You have them on empagliflozin, carvedilol, and spironolactone, just like our patient. He's also on torvastatin and aspirin, and between 2 and 4 milligrams of bumetanide twice a day. Really depends on what his needs are. The patient lives in Temecula, which is roughly about an hour to an hour and a half, depending on traffic. And he's doing whatever he can with taking all of his medications, and he's trying to avoid salt as well too. His cardiologist sends him for an evaluation for potentially CardioMEMS or advanced heart failure therapies. This is the typical patient that we see in our ambulatory referral. And our referral numbers have gone up throughout the course of the years. 2015 is when we started here. We started to build. We had, at the time in 2012, 2014, 4 transplant cardiologists, heart failure cardiologists. Now we have 12. So we build our program fairly fast. And I'm going to pull the curtain back a little bit and share with you some of the thoughts that we had as we built this program. You can see that this is an outpatient referral number. We're taking a look in 2015 all the way to year to date, May 15th, 2025. How many referrals we have to our advanced to our advanced center. This includes our satellite campuses as well. That includes Encinitas, my center up there in Temecula and Murrieta. And we also have El Centro, which is in the Imperial Valley. And a lot of our cardiology friends have sent their patients this way. You see a noticeable dip during the pandemic, and that's something that is fairly ubiquitous. But our referral numbers have gone up quite fast. And I want to share with you some of the stuff that we've done to ensure that these numbers stay up. 117 year to date as of about a month and a half ago, and then that number continues to go up. On the right hand side, you see our campus. We're very blessed to be very close to the ocean, and we have a very beautiful campus. If any of you've been here before. Usually when I present or I give a slide or I give a talk, there's always a slide that I save at the end and really spend a lot of time on that slide, sort of a summary slide. But I'm going to put this right in the beginning so that we can really glean from this and what we've done. What's important when you get the team out there. We bring a fair amount of our heart failure cardiologists. We call it the road show. We'll pack up and then we'll develop spoke interactions with a lot of our referring cardiologists. But our mantra is that the best abilities aren't the ones that determine the best hemodynamics read or the ones that really take a look at EKGs or figuring out what's going on with the cath. I think those are abilities that are inherent in our training. But the best abilities that we need to work on are availability, accessibility, and affability. Those are the abilities that really build programs. And that's our mantra as we get anybody that's coming into our system, getting out there and develop these types of relationships with our referring cardiology centers. In our introductory meeting, we don't take any lunch visits. We try not to visit any of the clinics during lunchtime. We don't think that having a brief 20, 40-minute meeting is suffice. I think what we like to do is to invite our referrals to dinners or happy hours. We do a fair amount of one-on-ones. So you'll see me go up there in Temecula, and then after my clinics, I'll have a one-on-one with one of the referring physicians. I think that's where you have the appropriate relationship building. It's not during lunches. You've been there before. You've had some folks that have gone into lunchtime, and yes, they've gotten you really nice Panera bread and sandwiches, but you got to keep clinic going, right? So we tend to do things after hours. We also have a symposia here at UCSD, and we have the whole office team be registered, and if their MD is interested. We have their MAs, we have their MPs, and we have their MD partners be registered to our symposia. We have 2 symposia, 3 if you include our Hawaii one. And we give them roles as well too. This is very important. Giving our MD referrals roles during the symposia, like a panel, goes a far way. And having our MD referrals be a part of this ownership program is something that we strive for. Number 2 is director's phone is always on. So my phone, they each have my number, and they call me anytime. The only time they can't reach me is when I'm on a cruise ship or something. Then we have other folks that can chime in. So when you have 2 to 3 directors like we do, it's very helpful. We have a transplant director, an MCS, cardiogenic shock director, heart failure director. So it's very helpful that any one of these referring cardiologists or NPs that have our number, they can call and get to us right away. I really do believe in the curbside. I think that helping them out in clinic or helping them out in the wards or in the ICU is important, but also be willing to do a virtual visit with their patient as well too. Now here in California, we can do that. We can do that within a week. I can set something up with one of my clinic times and see their patients, and at the very least get that patient into the UCSD system so that we can follow them and have our heart failure team see the play-by-play and see how they're doing if they're readmitted again. Having that close contact with these patients, even without seeing them face-to-face in person, is important for us. We have a phone call for every patient encounter. So if I see a patient that belongs to a referring cardiologist in Orange County, I'm on the phone with them right away. A lot of you already do this, but it's very important to teach our NPs to do the same. And we do have an NP to NP, PA to PA program as well too. So an APP to AP program where we'll get our APPs out there and to meet other APPs as well too. We know that our APPs are the front lines of seeing a lot of these patients, and oftentimes the referral will go through our advanced practice providers. So getting a face to a name and a chart is very important. Getting a face of our APPs to our referring clinics is very important as well too. And this is probably the most fruitful for us is patient take back. The patient takebacks are essential, both for heart transplant and LVAD patients. Now, we're not so involved with heart transplant patients, but we advise our heart transplant patients to continue to have that relationship with our providing cardiologists. Yes, in San Diego, that happens, but definitely for sure once they get back to the other counties in Southern California. Having that relationship is important because as they come back to the clinics, the staff is able to see that they're doing so much better. They're able to walk, they're able to breathe so much better. So the referral process becomes so much easier when the staff believes in what you see, when what they see. And I think what's really important are LVAD patients. These are patients that I accompany, and we'll go with the industry. We'll take the LVAD patients back to clinic. This is the only time that I'm there during lunchtime, and having a lunch with the staff as a take back is very valuable. Having them see a patient with an LVAD, seeing what an LVAD is valuable as well. And that threshold for referral drops dramatically once the office staff sees these patients. The last thing I would mention as well too is I would do what's called a take back symposia. So in our different counties, as we take our patients back to their clinics and all that, we do have a symposia just for our referring cardiologists. It's from UCSD. We rent out the place. We invite our referring cardiologists under one roof. And at first, I used to present these cases. So if I were to get a case or a patient from a particular provider, I'd present the case, and we go through the case and figure out what we did for the patient at UCSD, whether we recovered them. That's a great majority of times whether we LVADed the patient or took them to transplant or took them to palliation and hospice. I think it's very valuable to see what we do on that side of things as well too. What it's evolved to are inviting the referral MDs to present the cases, to present each of these patients in this type of symposium, and to say from A to B to see what they've done. And then once they transfer the patient to UCSD, then I take over and share with the teams what we've done for the patient. So I think these symposia are very important. I think what referral cardiologists really like to see is the opportunity to still own their patients, even though they've gone to a heart failure center. And we try to provide that for our referrings and part of the process. And the last thing that we share with our patients too, and something you can exercise, is the idea that once they're referred and they go towards transplant and LVAD, patients are, as you know, are super excited and they're very happy that they're able to do so much more. They say, "You guys saved my life. UCSD is the best." We turn it back and we say, "No, it's Dr. A who sent you to us that saved your life. It's Dr. B who found that you were in the throes of cardiogenic shock that sent you to us that saved your life. It's Dr. C who said, all right, this doesn't sound so right. Let me send you on over to Dr. Tran to see what his thoughts are." And then we went forward with the LVAD implantation. That's the doctor, Dr. C, who saved your life. So I think getting that mindset that the big part of the pie really belongs to our referring cardiologists during this process is very, very helpful. Okay, so I know that was a lot for this slide, but I wanted to spend some time just to talk about some of the mindsets that we have at UCSD as we built our program. So let's talk about some of the nuts and bolts. The definition of stage D, I wanted to juxtapose the ACC staging with the functional classifications in IRMAX. We talk about this all the time. We also now have SKY staging as well too, which I haven't included here. But the great majority of patients that I'm going to talk about are the patients who are advanced disease that are requiring hospital-based support, transplant, palliative care. I'm not talking about GDMT. That's a great talk that hopefully we'll have soon, but that's a stage C discussion. That interface between C and D is oftentimes blurry, and I think that we ought to spend some time talking about that today. If we're going to talk about INTERMAX, obviously INTERMAX or mechanical short-term support. This is what we use with the LVAD jargon and the LVAD vernacular. But INTERMAX profiling is very important for stage D patients, and you can see that juxtaposition here. So we'll spend a lot of time talking about the transition of C to D and what we do for our D patients. As you know, that transition is important. 1 out of 8 outpatient patients who are stage C will progress to stage D within 3 years. And you can see that mount up. You've seen it already. The numbers mount up. You've seen it already in your clinics. And so the idea is, how do you present a slide deck just like this to our referring cardiologists? 1 out of 8 patients died within that same period. That's way too much. That's way too many patients. 1 out of 4 patients either died or progressed to stage D within 3 years. So out of 4 of these patients that our referring cardiologists are seeing, 1 of them will pass away or progress to stage D within 3 years. We also have the ability to project. We have a heart failure progression score as well too that can be used. You can see the risk scores, which I won't go through so much on the left-hand side, but these are types of indices that ought to be in our mind as we're relaying a lot of this information to our referring cardiologists. Again, the slideshow and all slide decks and all that stuff, that will come later. The relationship comes first. Establish that relationship. Get them out for a happy hour, get them out for a dinner. And so we have a very vibrant business team at UCSD for that reason, is getting a lot of our referrals out. So does the patient have or is approaching stage D heart failure? Well, the clinical clues are this. Once an inotrope is started, one ought to think about stage D heart failure. Patients have really low ejection fraction. They're on GDMT and it hasn't really budged. Those are the types of patients that we ought to worry about. Patients who have 2 or more hospitalizations, like the patient that I presented to you, patients who have ER visits as well to decompensated heart failure within the last 12 months, those are important patients to think about. I'm going to segue a little bit and talk about ambulatory pulmonary artery monitoring. We deploy a fair amount of CardioMEMS, and we were in part of the Intertronics trials as well too. Using CardioMEMS or some sort of remote monitoring to earmark these patients is valuable. So I'll talk a little bit about how we've built up our remote monitoring team and how we helped out our very distant clinics with the remote monitoring team. Persistent heart failure class 3 or 4 symptoms. This is functional classification. Those are the types of patients that will give you clinical clues to be very worried about. High-risk profiling, biomarker profiling. So patients who have hyponatremia, patients who have really high BNPs, those are the patients we have to worry about. I would also include PA pressure profiling as well too. PA pressures is a biomarker. So if the PA pressures continue to be elevated, even though we're throwing a lot of diuretics and GDMT in a lot of our patients, those are the patients we ought to worry about as well too. Escalating doses of diuretics, those are patients that should be earmarked by referring cardiologists as patients that should be sent to advance heart failure cardiologist evaluation. And down titration, we see this all the time, down titration of GDMT. Either the patient is hypotensive, a little too dizzy, or excessively fatigued after that beta blocker up titration, or patients that can't tolerate a higher dose, largely because they have some blood pressure issue of 105 over 70, right? So those patients in your institutions, in heart failure centers, we're not afraid of a 105. We're not afraid of 98, even if they don't have any symptoms. So getting the benefit of really pushing GDMT when GDMT is taken off in a heart failure center will be beneficial as well. Other clinical clues is discontinuation of medications, maybe a progressive rise in their creatinine in renal failure patients, and medications are taken off. Recurrent AFib or VT with ICD shocks, patients that are non-responsive to CRT therapy, cardiac cachexia, patients with high risk mortality with prediction modeling and calculators. We've done that in the past. We have a marker score developed at UCSD that I'll go through in a little bit. This is a quick mnemonic that we send out to the community. This is a mnemonic that has been passed around for the last decade. If you take a look at any patients that's on IV inotropes, any patients that are in YHA 3B or 4, end-stage organ dysfunction, patients with an ejection fraction less than or equal to 25%, that's pretty stubborn and can't get a little higher on GDMT. Any patient with defibrillator shocks, hospitalization greater than 1 in the last 6 months, patients with elevated PA pressures despite escalating diuretics, as in monitoring with CardioMEMS, patients with low blood pressure or high heart rate with orthostatic symptoms, prognostic medication changes, these patients that have down titration of medications or progressive intolerance of these medications, INEEDHELP, so I need help. A great mnemonic to be posted somewhere in clinics that are in your referring cardiologists centers, and some of the PCPs that we've had as well too up in those areas. CRT non-responders, as you can see there, and physical activity limit or impaired quality of life. those are very important clinical clues for referring cardiologists. We also share that patients who've been living with heart failure and have a very big LV, those are the patients that we're really worried about. As you can see in that snapshot on the right-hand side, very big LV. This patient's been dealing with heart failure for some time. Patients with significant secondary mitral regurgitation and the presence of pulmonary hypertension. A quick little message in that second bullet. Secondary mitral regurgitation, they may be a candidate for LVAD or transplant, but we also take a look at them with our heart clinic, our structural clinic for potential MitraClip as well too. And we have a multidisciplinary effort figuring out what is the right step for our patients. Many of these patients will go towards LVAD or heart transplantation. Restrictive mitral inflow pattern despite efforts to decongest this patient is a very bad prognostic sign. And concomitant RV dysfunction as well too. We all learn from medical school the biggest reason for RV dysfunction is LV dysfunction. So in time, as RV is having some difficulty, that may be the time to send them to an advanced heart failure cardiologist. The evaluation treat any reversible pathogenesis. So we take a look at high-risk PCI, CTO revascularization as well, untreated arrhythmia, high-risk Impella-assisted ventricular tachycardia ablation is something that we do a fair amount of at our center. We'd look at treatable causes. Again, we would attempt GDMT. Now, this is that broken wheel, or this is that beating a dead horse, right? So if our referrals are trying GDMT, we have a very low threshold to see if they can tolerate more, but again, a very low threshold to say we've tried this before. This is that broken record, and we want to push forward to advanced therapies. A very low threshold, again, to take a look at CRT for those who don't have CRT, who may be candidates for CRT. We have a multidisciplinary effort in taking a look at non-cardiac comorbid conditions as well, too. I won't spend too much time on that. I'm sure that your centers have something like that. But a lot of our referring cardiology clinics don't have those resources, and offering those resources may be very helpful on top of their cardiac issues. So in ensuring adequate support system to allow adherence, that's something that we can work on. They may not be resourced to be able to ensure adequate support, but that's something that we have. We have a very vibrant education team as well too, and now that we've gone fairly, we've done well virtually, we have our heart failure education team talk to these patients and spend a lot of time educating our patients as well. So this is a clinical course that we had seen a long time ago from Dr. Georgiati in the past as a patient having heart failure and ultimately getting placed on GDMT. Now, obviously, sudden death they're at risk for, but they get placed on GDMT and there are some bumps along the way, some decompensations along the way until they get to end stage heart failure. The idea is that we want to be able to figure out what this golden window is for referral before it's too late. And the patient's too late when you have multi-organ dysfunction. With that said, we do a fair amount of multi-organ transplants at UCSD. When a patient gets to severe malnutrition or cardiac cachexia that's unresponsive to supplementation, that's too late. We have a fair amount of patients who are frail, and they're too frail by the time that we see them, that the frailty becomes too big of general frailty. Now we can fix the cardiac frailty, but the generalized frailty is a little difficult to fix with an LVAD or with a heart transplant. So getting this message out there to our cardiologists is essential. There is that golden window, and every single patient has a different type of golden window. That time varies. That could be short for some patients, long for others, but understanding when to refer as in I need help is very helpful for our referring centers. What we're looking for, again, are symptoms, functional symptoms, intolerance to GDMT, frequent hospitalizations, patients with recurrent arrhythmias and ICD shocks, and worsening renal function. Let's take a look at clinical case number 2, an inpatient transfer. We have a 42-year-old gentleman with a lower EF, an EF of about 20%, with an ICD. He also has coronary disease, so ischemic cardiomyopathy, had PCI and a CABG as well too. He was in a local hospital in Vegas. We do get a fair amount of Vegas patients, up to about 15% of our patients are from Las Vegas. He complains of abdominal pain and fullness. diagnosed with cardiogenic shock, acute renal insufficiency, and hepatic dysfunction. He was started norepinephrine, dobutamine, diuresed. You've seen this story before. These patients are very, very sick. These patients come into the hospital in cardiogenic shock. And granted, they're cardiogenic shock, there's a fair amount of heterogeneity. This is not an AMI cardiogenic shock. This is a coronary arterial ischemic cardiomyopathy with stage D cardiogenic shock coming in. So this is a stage D heart failure patient with shock. So we were called for transfer of this patient. His heart rate was 108, blood pressure was low, 89/43, and he was satting 98% on 2 liters nasal cannulation. So he was flown in from Vegas, and once he got to us, he was cool and clammy. He was jaundiced upon arrival. Supesio is our cardiovascular center. His blood pressure is lower than billed, heart rate higher than billed. He did not have a Swan-Ganz catheter. He did have a peripheral venous saturation of 35%, so fairly low. Peripheral venous saturation, take it with a grain of salt. He had hyponatremia. He also had a BUN 125 and a creatinine of 3.75. ALT that's elevated, AST that's elevated, and a T-Billy riding on close to 30. Lactate of 6.4 and INR 2.5, and you can see his echocardiogram on the left. It's barely moving, right? So we've got to figure out what's the next step for these guys. We see a fair amount of these patients. And I can share with you, getting this patient maybe 6 months ago probably was that's the golden window, right? And having patient referred during that golden window is so helpful. But this patient is in the throes of cardiogenic shock. We've got to figure out what the best steps are for this patient. I can tell you for this patient, he ended up getting an LVAD, and we had a temp RVAD helping him out for about 2 weeks or so. This was a heart wear case, and we were able to get him off the RVAD, got him off CRT. He lived with his heart wear for about a year and a half, ended up getting transplanted. So a happy story for him, but we pushed hard largely because he was in his 40s and he had 2 kids, and we wanted to get him to these quick. What we share with our referring centers is that when a patient has cardiogenic shock, as defined by clinically, a blood pressure that's low, as you can see here, less than 90 millimeters mercury, a lactate that's elevated, or signs of end organ hypoperfusion, a urinary output that's less than 30 cc's an hour, creatinine elevation, or altered mental status, or cool skins, cool extremities, right? Once that happens, once that occurs, we have our referring cardiologist give us a call. And the person that has this number is our advanced heart failure cardiologist that's on call 24/7, and this advanced heart failure cardiologist will then round up the troops, and we talk about our patients and figure out what the next best steps are for our patients. We actively take a look at cardiac power output for our patients. We take a look at API for our patients, aortic pulsatility indices, and also the pulmonary artery pulsatility index as well too, as we justify certain steps towards mechanical circulatory support. So this is a diagram showing what happens once a spoke referring hospital calls this number to one of us on call, or they oftentimes text me or call me directly. And we get our shock lead together with heart failure, interventional cardiology, and cardiothoracic surgery. Once we have that discussion and we confirm that we understand what the next steps are for this patient, then we will inform our transfer center that we'll take this patient on. What would guide us ultimately is this pathway where we can deviate from this pathway, but having a phenotype of hemodynamics for our patients is important. One of the roles that we have in our community is really to push the appropriate use of PA catheters, Swan-Ganz catheters in cardiogenic shock patients. Sure, there's a lot of difficulty in pushing for that in the ICU, but guess what? We have a lot of events for our intensivists in Temecula Valley Hospital, at St. Joseph's in Orange County, at Loma Linda Murrieta. We get a lot of the intensives together and go through the data of why a PA catheter would be useful. And in fact, the cardiogenic shock working group is working towards justifying this PA catheter as well too in their study. So a lot of bringing the referring cardiology centers, referring hospitals up with our relationships and getting them used to Swan-Ganz catheters. And in fact, we have a relationship where we offer rotations for their fellows. So as they spend a month with us at UC San Diego, they come back armed with all this knowledge on how to deal with shock and transplant LVAD patients, that the latter two may not be germane to their hospital system, but at the very least, offering the idea of advancing their shock approach. Now, I'd be remiss not to talk about specific populations that could be suffering from late referrals. We know that heart failure does not discriminate. The incidence of heart failure, as you can see here in this ACC-HA-HFSA analysis, we can see that there's an even splay between folks who are women and men with heart failure. But when you take a look at heart transplant recipients and also LVAD recipients, as you can see here on the right-hand side, there's a great disparity. So what is it that we are doing as a community that isn't evening this playing field where enough women are being are suffering with advanced heart failure and they're not being referred? So that message has to be placed across as well too. As you can see here, transplant by gender, a great majority of patients who are transplanted are men, large minority women. You can see here on the right-hand side the disparity with ethnicities as well too. White is on blue, which is on top, the great majority of our patients, Black, Hispanic, and Asian and others, as you can see here in the other lines. And social determinants of health is important. Under insurance, low income, low social support. We started our outreach really taking a look at a zip code analysis of how many patients are being reached by something like sacubitril valsartan. SGLT2 inhibitors. Taking a look at some of those zip code analysis will tell you that, listen, maybe there are heart failure patients that are out there that are not being reached, and we try to reach those centers. We started Temecula with that type of analysis as well too. So it's important figuring out where regionally where the disparities are. In the last 15, 20 minutes or so, I'd like to talk a little bit about the advanced heart failure centers and what they look like. And as I lead off, the rest of the other faculty members will speak a little bit to their own centers and what they see in terms of these patients coming through. So if a patient is considered advanced, based on the clinical criteria that we've seen previously in previous slides, then we ask for this referral. And what we do is that we share with our referring providers what happens. So these types of slides are important to share with our referring cardiologists, primary care doctors, and our advanced practice providers as well. What does that look like? Well, this is a look behind the curtains in an advanced heart failure center, a lot like ours, taking a closer look at heart failure etiology. How many times have we seen an amyloid patient come through? How many times have we seen a patient that was concerned with amyloid actually have hypertrophic cardiomyopathy, right? Those are the types of relationships that we build after seeing the HFrEFs. And now we're seeing a fair amount of HFpEFs come through with our advanced heart failure clinics. So we assess the the heart failure etiology. If we feel that GDMT hasn't been applied, then we will apply GDMT quick. We have a pharmacy team that does a fair amount of virtual GDMT visits. And so when a patient comes in and we start them on a moderate dose of Entresto, we don't have to wait a month. They can be seen in 2 weeks and have these medications up titrated. And by the time that they see me next in clinic, they're on the full gamut of 4 pillars of HFrEF therapy. And so we very quickly monitor if they can tolerate these medications. I'll go through some of the additional therapeutics. I have a slide for that, and ultimately talking a little bit advanced therapies. We cannot ignore the advanced practice and goals of care for a lot of these patients. So at our center, we do a fair amount of endomyocardial biopsies on native hearts, figuring out what's going on with our patients. We have a genetic counselor and we have a genetic cardiomyopathy clinic that's headed up by Dr. Adler and Dr. Bowie, and we'll send our patients to genetic counseling if necessary. We have pedigree analysis as well. We have advanced imaging, cardiac MRI and PIP scanning that is necessary for a lot of our patients coming in, chronic myocarditis, amyloid patients, patients who have sarcoid as well. We'll send to the appropriate imaging studies. And obviously, getting a great idea of what a patient has will significantly change their trajectory as we push forward with therapy on some of these patients. Heart failure and comorbidity management. This is where we offer that multidisciplinary effort, getting everybody together that can potentially help out with this patient. We have patients that will drive 2 hours, 2.5 hours, come down just to see the endocrinologist that we set up, a rheumatologist that we've set up for them at UCSD, on top of seeing us in our heart failure clinic or advanced heart failure clinics. This is the connection between the circles of clinic to home. So this was published about 2 years ago, taking a look at the multidisciplinary effort of seeing a lot of these patients, and a lot of these patients in a remote setting as well too. So it's very important that once they're sent here, two things happen. Number one is that the referring is always involved. We always send this patient back if there's a left heart catheterization that needs to be done. We'll send them back if an echocardiogram can be done and followed up at their center. This cannot be that black box. It has to be a bidirectional communication with our referring cardiologists. And we'll have a lot of remote monitoring as well too for our patients, particularly in the remote setting. We have a very low threshold to employ CardioMEMS, which we'll talk about a little bit later on, and have a shared care model with our referring cardiologists, in that we can utilize our team for CardioMEMS monitoring. But when it comes to seeing this patient, they're seeing them one-on-one. Every single time we make a change with CardioMEMS, their clinic is informed. So GDMT, we spoke a little bit about this. We do have a fair amount of trials that had buoyed the 4 pillars of therapy that we have now. We do have a very vibrant pharmacy team that we work with, and we're very lucky that way, in that we have a school of pharmacy and a big pharmacy involvement here at UCSD, but the referring centers may not have that. So offering that as a potential resource that they can take advantage of is very helpful. And a lot of times I'll see a patient in the remote setting that all they really need is getting our pharmacists involved and getting our educators involved, just to keep them out of the hospital. And they don't need CardioMEMS, they don't need advanced heart failure therapies, and that's very helpful as well. We have cardiopulmonary exercise testing. We do prognostic scores as well too. That's something a lot of the referring centers do not have. I talk a little bit about cardiopulmonary exercise testing. I talk a little bit about the scoring system we have at UCSD. This is a machine learning based model that we have, taking a look at a scoring system, and a very good accurate scoring system that we've externally validated as well too. So we plug our patients into the scoring system and see where they're at, so they can actually see what their progression is. And very similar to the Seattle Heart Failure score, that you can sit there on a desktop taking a look at that stuff with your patients. And the advanced centers, we talked a little bit about CardioMEMS. We do have TAVR, we do have TEER as well too, and so a big multidisciplinary discussion can happen at our center. I tend to always inform our referring cardiologists that we're going to be talking about this, and that if the patient is appropriate for TAVR and their institution can do TAVR, I give them the first right of refusal. The great majority of times, because these patients are sicker, our center will implant the TAVR and we'll follow these patients together as an outpatient. We have patients that have BIVADs. This is a patient that had BIVAD. He was very sick and then ultimately got a transplant. So you're taking a look at sort of a reversal of age almost, right? He looks so cachectic on BIVAD support, and he's so very young. He was, if you can believe it, in his 40s here, in his 50s here on the right side. So showing these types of cases, bringing these types of patients back to their clinics, their referring clinics, to have the staff see is so important. We also have a very vibrant palliative care team, although palliative care services have been cut recently across the country. We do have a vibrant palliative care team that can talk to our patients about the control of symptoms and what it means to have quality of life. So the discussion summary so far is taking a look at challenges in advanced heart failure. We've taken a look at patient identification in the outpatient, inpatient realm as well too. I took a look at the referral process and the advanced heart failure team. It's all buoyed by this "I need help" mnemonic. So that is very mnemonic to send out there to the community to see. In the last 5 minutes, I won't spend too much time on this, but remote monitoring is huge for us. We use remote monitoring to be able to bring patients to us and have that bridge for these patients that live in the outlying community centers. We know that patients that get out of the hospital tend still to be congested. This is a study that was done by my good friend, Dr. Lala, and 90% of patients that come to the hospital are oftentimes have some form of congestion, i.e. pulmonary congestion. At discharge, taking a look retrospectively at the dose and the Caress heart failure trials, 40% of these patients continue to have some form of moderate to severe congestion via an orthoedema index. 60% of these patients have an absent or mild congestion, but if you follow up these patients in 2 years, in 2 months, these 41% of these patients have some form of congestion. So we have inadequate ways to keep our patients monitored because we're only seeing the tip of the iceberg, whether it's in clinic or in the hospital. A lot happens underneath the water. We've tried that in the past with signs and symptoms and calling them for signs and symptoms and daily weights, taking a look at telephonic support. We've employed our ICDs to try to do this as well too, but nothing's really worked. So we feel that it was too reactive and inexact as these symptoms build up towards hospitalization. We wanted to be more proactive and actionable by taking a look at filling pressures prior to some of these symptoms happening. And that's why you've seen this for the last 15 years. Ambulatory pulmonary artery remote monitoring is important. I won't go through all the clinical studies of CardioMEMS, but it's important to know that it's been tested it's been tested prospectively with the Champion trial, the Guide trial as well too. We have the Monitor study over in Europe, and that has led us to this January, so roughly 6 months ago, in this national coverage determination for CardioMEMS. So we use this a fair amount. We have an example of a UCSD patient that had multiple hospitalizations, but then ultimately you can see that huge area we're able to bring the pressures down on our patients with 0 rehospitalizations. As with everything that we deploy for our patients and implant, patient selection is so important. This patient, CardioMEMS didn't help. Unfortunately, he was homeless, and there was a period where he wasn't able to really record his device as well too. So patient selection for CardioMEMS is very important. We have a weekly huddle. It's a weekly Wednesday AM huddle where our nurse and our PA, our heart failure nurse and heart failure PA, who take a look at these numbers, report these numbers back. Our clinic heart failure nurses are part of this huddle as well too, as am I. And what I do is that I'm on my phone or my computer. I'm communicating with a lot of our referrals and a lot of our internal cardiologists who have referred patients for CardioMEMS, and sharing them what I'm doing for their patients via phone call or internal communication via Epic. We do have an Abbott rep that's there in case we have some technological issues with CardioMEMS as well. So this is a weekly meeting that we have, and this is a meeting that we offer to all of our referring cardiologists who send their patients with CardioMEMS, either implanted at their center or implanted at our center, that they can follow. And I'm going to be, in the last 2 slides I have here, this is a conventional hierarchical teams approach for our heart failure director. We have a heart failure director. I took over as heart failure director last year. We had different committees and all that with different physician leads and different physicians that were part of this. And I felt that this was too rigid. It worked for a while, and it's too much of rigidity. What I created was a teams of triadic networks. I'd like to give a shout out to Moby Montessa, Joy Sell, Kim Hong, Paul Hansen, who represents my inpatient team. Kim is our physician lead from this. Our outpatient physician lead is Quan Bui, and Nick Frenner is a general cardiologist, and Laura Holcomb is our clinic supervisor. They represent my outpatient clinic team. And Jessica Lynn, Hillary Shapiro, and Karina Brown. Hillary is our physician lead for heart failure education. They're tied together. And finally, I have Dr. Ben Cruz and Antoinette Beers, who are my physician leads for GDMT, with our pharmacist Trina Nguyen and our IT cardiologist, Matthias Ramses. I couldn't have done any of this build in this last year without these individuals. So I don't have their pictures, or their pictures would be all over the slide, but I wanted to give credit where credit is due. I'd also want to challenge you as you're creating some of these teams of triads and quadrads to have these members meet and talk to each other. So kind of embed these members together and have those types of relationships as you're leading the heart failure clinics and heart failure services. So thank you to all these individuals for the creation of a very vibrant heart failure team and advanced heart failure team. That is all I have for you. I'm not going to be available for questions, but I'm sure we'll have some way that you can get a hold of me. Thank you for your attention, and again, apologies for not being there live.
Yes, thank you so much, Dr. Tran. If anybody does have questions for him that you've submitted in the chat, we will take those and we can follow up with him to reach out to you and answer those. But I want to thank you again, Dr. Tran, for sharing your knowledge and the models that you have at UCSD with the audience. This was really great. And I'd like to let you all know that coming up next at 2 p.m. Central Time, we'll have our next session titled Bridging the Gaps, Overcoming Barriers to Advanced Heart Failure Care in Rural Areas. And to access that, please exit this session, and then you can return to the lobby using the main menu at the top of your screen. And from the lobby, you can click the Sessions tab first, and then click the individual session to join. Thanks again, and we'll see you shortly.